Okay, well, we are at noon. Excuse me, I have this phantom cough going on. We'll go ahead and get started, I guess, or we can wait a minute, but we have an intimate group and we are glad to have everybody here with us today. With permission, I'm going to record this so that we can offer it on our YouTube channel for the Department of Pathology going forward. And so this is the second in our series of the Tweet and Eat, we were calling it communications, sort of outreach and just engagement program, just to get people talking about what it means to be involved with communications as a clinician, as a researcher, as a faculty member, as a staff member, in whatever way you might be, especially at an academic medical center. And so today we are lucky to have Dr. Greg Davis and Jeff Gravlin joining us on the topic of networks old and new. And they're going to tell you a little bit more about what that means, but I'm going to go ahead and read their bios for you. Dr. Davis is Division Director in the Department of Pathology's Forensics Division, Forensic Pathology. Forgive me, I don't know exactly how long you've been with the department.
Many years.
Many years, okay. But he is a graduate of Vanderbilt Medical School, and he trained there in pathology at Vanderbilt University, and followed that with a fellowship in forensic pathology at San Diego County Medical Examiner's Office. So also out on the West Coast. He then joined the faculty at UAB, where he is a professor and director of the Division of Forensics. He is also the chief coroner and medical examiner for Jefferson County, which is obviously where we are here in Birmingham. He has a Master of Science in Public Health from UAB School of Public Health. And his research interest is the application of epidemiology to the study and practice of forensic pathology with a focus on drug-related deaths. Specifically, I think mostly opioids, but correct me if I'm wrong. Right. So he has published 75 or more peer-reviewed manuscripts and served on as a lead author on the 2013 opioid position paper, of the National Examiner of Association of Medical Examiners, NAME is what we call it, and on the updated paper, which was published last year. He serves on the editorial board of several journals and is a member of the CERT-Link Test Development Advisory Committee of the American Board of Pathology. He's also a fellow at-large director on the board of directors of the American Society for Clinical Pathology, ASCP, and is a past president of NAME. So welcome, Dr. Davis.
Thank you.
And we also have joining us today, Jeff Gravlin. He is a professor and associate dean for research and scholarly communication and director of the recently formalized Office for Scholarly Communication. Jeff is a professor and the associate dean, as I mentioned, and director of the office. He's actively involved with the Alabama Library Association, the Association of College and Research Libraries, and the Alabama Library Association. His research interests include the intersection between copyright law and higher education and leadership in academic libraries. He has been a regular speaker on copyright and authors' rights for more than a decade, and he holds a Bachelor of Arts degree in history from Virginia Tech and a JD in M.L.I.S, which is Library Information Sciences, is that correct? From the University of Alabama. So he's going to speak with us a little bit about the new office that was formed on scholarly communication and on copyright. So another facet of not necessarily communications, but something you might come across in your work. So with that, I think we'll go ahead and let Dr. Davis start. Did you want to share your slides?
Sure, go ahead.
Okay. Just a second. Or actually, I don't know if you wanted to do it now or throughout.
Oh, I see. This is the first slide because you changed them, right? Is the only other slide the one with the list?
You had two slides.
Right. I'm not ready for the one with the list yet.
Okay. I'm sorry, hold on just a second. I'm gonna have to
Oh, it's no
switch.
problem. Oh, we got more people on than it seems like.
We do. We have 15 people on.
Yeah.
I'm trying to find the other presentation I have open here.
Grief.
There we go. There we go. Is that working?
Yeah, that's fine. Although this is the part I don't know how to do. So I don't really need that for the time being. I was just gonna talk to people.
Okay.
We were sitting and talking.
We can pause it and then turn on the other one when you're ready.
So I'm sorry, where are the controls?
I have the controls, so I paused the screen sharing. So if you want to just
so just show me for now.
Okay. Is that what everyone is saying? I'm sorry.
Okay.
Okay. There we go.
All right. So thank you, Christina. Thank you for those who've come to participate. So I'm actually going to start with a couple of confessions. They're stronger even than disclaimers. So that's why I call them confessions. The first is I had in my mind that this whole process that Christina has put together was to try to help us understand and use social media better. And perhaps I'm right, perhaps I misunderstood. But the first confession is I don't really use social media. And I send text messages and I get and receive email, but I'm not on Facebook. And I check Instagram to see what my daughters may have posted, but I'm not really tweeting, and I'm not creating a social media presence for UAB. So that's my first confession. My second confession is that I confess that I actually was attracted in part to pathology as a specialty to practice because I had perceived that pathologists didn't really have patient interaction. I liked patient interaction a little bit, but not a lot. Just a little bit of patient interaction was plenty for me. And so I went into pathology. And then I went into forensic pathology. And people have the idea that forensic pathologists have no patient interaction because, of course, our patients have all died. And that's why we're examining them. But I quickly learned that forensic pathology is not void of patient interaction. Forensic pathology comes with the family members, the relatives of patients, and they very much want to talk to forensic pathologists to find out what happened to the person that died, whom they love. I mean, they care about. It was their family member. And initially, when the calls would come in, I knew the answer, but there was still a part of me that thought, well, why is it there's some clinician that's taking this call and I don't have to do this? But of course, there was no clinician because there was no one in between us. I was the primary care physician for this person who had died. And so I had to take out and dust off some of my patient interaction skills that I had been taught as a medical student and then developed to some extent as a medical student. And they weren't too hard to dust off. And I actually grew to like patient interaction. So that's some of what we're going to talk about in a bit. But I want to emphasize at this moment that right now in pathology and for the past 5 or 6 years, I've been hearing a lot of talk of what has now come to be under the heading of pipeline. We don't have enough new people coming into pathology, whether as a pathologist or as a laboratory practitioner, a bench laboratory technician of whatever sort. We don't have enough people in the pipeline. And there's a lot of hand wringing and wondering, how can we get people into the pipeline? Well, I'm here to state that part of our pipeline trouble is that people don't even know that we exist. So my perception that pathology was free of patient interaction, which in fact is untrue, but that perception of a desirable state where you don't interact with patients and they don't really even know that you exist, that's created a lot of our pipeline problem. And we have, how can people enter into laboratory practice if they don't even know that you exist? And so now I make a great point. I'm always asked when I testify in court, well, what is it that pathologists do? I have to establish who I am as a professional and what I do and why I would even be qualified to speak on the subject I've been asked to testify about. And when I talk about pathology, I turn to the jury members and I say, you may not have met a pathologist, but whenever you go see the doctor and there's a tube of blood taken from you, it goes to a pathology laboratory. If you've ever had a biopsy or someone who had a biopsy to see if they have cancer, it goes, and they say, well, we're waiting on the results. They're waiting on pathologists. And so you've actually, all of you have had interaction with pathologists, you just didn't know it. So the Cures Act is the last part that's going to tie this all together. The Cures Act is law that's been passed that says that patients have direct access to their medical records, including their pathology report. And I've heard some discussion or various statements from various pathologists saying this is terrible. They could just reach out and call me on the phone. They could find my email on UAB's website and contact me. And this is devastating. And I'm telling you, it's not devastating. It's the best gift that we could have possibly received as pathologists. We kind of boxed ourselves in. We had said, well, we'll let clinicians talk to patients and we won't interfere. And clinicians will be in charge of everything and we'll just kind of whisper in the clinician's ear. But somewhere along the line, we forgot that clinicians are never going to talk about how grateful they are to pathologists, to the patient. They cut us out. And by having patients come directly to us, we'll be able to explain things to patients and interact with patients. And that'll be a great benefit. It'll benefit both the patients and it will benefit us. So I'm going to talk first about how it's going to be a benefit to the patients. We'll be able to explain the diagnosis and how we reach the diagnosis directly to the patient when patients contact us. I think all of us as pathologists know that clinicians are not capable of making the sorts of diagnoses that we make, particularly using microscopes or interpreting certain findings that we may have. They can read our lab reports, but the clinicians don't create the lab reports. We're the ones who create the lab reports. So we're the ones best able to explain to patients what it is, why it is that they have cancer. We can do that. And we can do it better than anyone else. And when they're asking that question, how do you know that I have cancer? We're the ones that should be answering that question. We also will benefit patients that by knowing our limits. That's a very important point or very important skill that I need to have when I'm in court. If they start to ask questions that are outside my area, then I need to defer and say that you have this really doesn't pertain to pathology. You're talking now about like bullet examination, and I look at bullets, but I don't examine them to figure out what gun they came out of. You need to ask somebody that does that sort of work that question. For us, it would be, I'm saying clinicians aren't really as qualified to describe how pathological diagnoses are made as pathologists are, but I'm not really that qualified to talk about what a patient can expect as part of a chemotherapy regimen, for example. I have a general idea, but their clinician who will be working with them and treating them throughout the course of their chemotherapy is far better suited to answer that sort of question. So really, it's just an acknowledgement of the team approach to how medicine is practiced these days. And then finally, the patient will not only understand their own diagnosis, but they'll have a better understanding of how healthcare is really practiced today and how the different physicians interact with each other. And my hope is that that will actually help patients to have confidence in the healthcare system. It's not just one person that cares about you, it's many people all caring for you, each in a way that they are uniquely qualified to do, and they're all bringing that together to try to help you get well. Or I'll acknowledge, if it's not that you'll get well, it may be that you have a disease that will end in your death. We can still work together to try to make the time that's remaining as enjoyable, if I can use that word, but and as beneficial to you and your family as we possibly can. That's what we're here to do. Well, those are all things that'll benefit patients. So let's talk about things that'll benefit the pathologists. I've already alluded to one, and that is that we will be better known. People will even realize that we exist, and perhaps, just possibly, they may decide that working in a pathology laboratory would be a good thing to sort of consider as a career. I didn't really know any pathologists, so I never considered that I could work in a pathology laboratory until I was exposed in medical school. Had I not taken a search path rotation because I thought it was interesting, I'd be out practicing primary care, I guess, or something, I don't know, something in internal medicine. And I wouldn't be as happy as I am now because I would be in the wrong circumstance. I'm made to be a pathologist. So happily, I got that exposure. And by interacting with people, we can give more people that exposure to pathology and what pathologists are and what they do. And that we're not some sort of strange little bird that no one will allow to interact with other members of society just to protect society from pathologists because they're so quirky. No, we're just people. We may have an unusual job, but we're just people like them. And we're happy to do what we do because it's helpful to other people. We'll also have some grasp, which we don't have at all now, of how much patients appreciate the work that we do. They do appreciate it. One of the most vivid memories I have at a meeting, and I am a forensic pathologist, but a woman got up and she was talking specifically about mass disasters. In her case, a plane crash. And she actually started to cry a little bit. She had to dab at her eyes as she was speaking, but she said, "You have no idea. You do not know how important the work that you do is to people that you have never even met, but they are all supremely grateful for what you do. And I wish that you could understand it and that I could explain it to you the way that I feel it inside, having been there." That's a pretty powerful statement, of course. And I think that people with cancer or people with pneumonia or whatever it is that ends up needing a pathological diagnosis, I think they would share that same degree of gratitude with pathologists. Every one of them? No, of course not everyone. But some of them will. And it just takes one shot in the arm every once in a while to help keep you doing what it is that you do with the conviction that it's really important and it really matters. And even when it's kind of a grind, you keep doing it because it's the right thing to do, and you know it because people have reminded you of that. The final way in which I think it'll benefit pathologists is the more tightly or the more clearly it's visible to everyone how tightly we're woven into medical practice then the more difficult it will be for anyone, particularly, I hope, hospital administration, to ignore the needs that pathologists have, needs for space, needs for machines, needs for new faculty, all those sorts of things. If people don't realize we exist, if they don't realize how important our work is, and if they don't realize that they need to make sure that we perpetuate it, then we're going to have the sorts of problems that we have with the pipeline. We've all seen this with the response that we got because of COVID for how important laboratory work was, and people hadn't realized that. Now, those are my pitches for why we should be doing this, but let me at least be honest enough to tell you that it can be an uncomfortable experience, particularly at first. And I've thought about that. Why is it so uncomfortable? And I think I know the answer. If you're doing it properly, it's uncomfortable opening yourself up to a patient because you're actually making yourself vulnerable. You're vulnerable in several ways. We all are busy. We've got a lot of work to do. And if you offer to speak with someone that just called or tried to contact you, even if you arrange an appointment later that day or on the following day, which is fine to do, they just know their voice was heard and that you'll talk with them later. Even when it's scheduled, you're still giving up some of your time to help this person. And giving up your time makes you vulnerable. You're also vulnerable because you can look at the slide and make a diagnosis of some god-awful disease, but maybe it doesn't affect you so much because you're separated from the patient. But when that patient with a god-awful disease calls you to talk with you and ask you, how can you know that I have this awful disease? Then that makes you vulnerable as a human being. I have that experience regularly when I talk with family members, but I'm here to tell you that that experience is what makes it a meaningful experience, both for the patient and for you. It's that give and take, that sharing of our common humanity that gives the things that you're saying to the patient power to help them know that they're cared for. If you just read it out of a textbook without any inflection in your voice, like you don't really care, then the patient isn't going to get much out of that. But if you take the time to explain it to them, person to person, because there's someone that you care about. If you don't care about them, I suggest that you start imagining in your head that the person who's called you is someone that you do care about, and explain it to them the same way that you would explain to your friend who doesn't know medicine, but whom you care for, and you want to help them understand this particular aspect of medicine. When I do that, it's really not that hard to do. It's that vulnerability, as I'm saying, that makes us credible and gives what we say particularly resonant power when we talk with patients. You have to do the same sort of thing in talking with the patient that I'm doing now. You got to get rid of distractions. Before this started, I turned the sound off on my cell phone. I'm not glancing over to see how many text messages came in or anything like that, because right now, my focus is on this talk and really on you, the people who are hearing what I'm saying. You've got to give them that sort of attention. That's part of how patients know how important it is to you, how much attention you give to them. When you're talking with patients, or anyone really, it can be helpful to know that usually they either lead or end with the thing that's most important to them. In my experience, they usually lead with it. And so they'll say, you pick up the phone or whatever, you're talking now, you introduce yourselves, and then say, I always say, how may I be of service to you? Because that's what I want to do and remember to do, to serve these people that have called on me. And then they'll ask their question. Often it's not the sort of question that I had expected. And I'm going to come back to that point because I think that's part of what would actually make this experience easier for pathologists. I think we have a misunderstanding of what patients are likely to ask. Sometimes the question that they're most interested in is at the very end. But if you get in the habit of paying attention to the first statement and the last statement, you'll catch a lot that you won't hear in the middle part. So let me make good on my promise. Let's come back and talk about what it is that patients are going to ask. Because when I hear pathologists talk about concern with describing things to other people, they seem always to have honed in on the part of the diagnosis that was most difficult. And believe me, I know there are difficult diagnoses that have to be made, difficult gradations of judgment. Is this thing a mild dysplasia? Is it moderate dysplasia? Is it severe dysplasia? The ones that are right smack dab in the middle are easy, but those ones that sit the fence are really difficult. And so, because that's the thing that's of most importance to you, I think we tend to think that's the thing that's going to be most important to the patient. That's what they're going to ask about. And then they're going to say, well, how do you know it's moderate? I thought it was mild. And they've thrown you back into your quandary, your diagnostic quandary. But that's probably not what they're going to ask. What the patient's going to ask is, what is dysplasia? This is affecting my life now, and it's upended my life, and I don't even know what it is. Could you please explain what dysplasia is? And then could you explain how you know that I have it? Those are the sorts of questions that patients ask, and you're able to explain it. And with a little practice, because they'll tend to ask similar sorts of questions. It's different people, but they're going to have similar sorts of questions. Then you actually get more comfortable with it and have a little, you can tell from experience, this worked. I tried this analogy and it worked. You tried the next time and it worked. That's probably a pretty good analogy to use. If you're using it, it's not working, you're going to have to shift and find a new analogy and till one works, and then stick with that and you embroider on that as time goes by. Let me see, I'm going to check my time because I've got myself so free of distractions. I don't even know what time it is, but I see where I am. And I'm going to check my notes to see if there's something else I haven't mentioned that I want to mention. Oh, yeah. So don't use doctor speak when I'm talking to you. I use the word dysplasia. You really can't get around that, but I haven't used lots of medical terms. I'm just talking as one human being to another. I hope my sentences are well formed and that you don't think I'm a simpleton, but I am in fact trying to use the simplest words that are required to transmit the information that I want to transmit. Let's see. Oh, yes, and I wanted to make this point too. So if you're concerned or think I can't explain all this to another person, it's just too complicated, they don't have my training and all that, I want to reassure you that actually we have a great advantage. My wife teaches physics. Physics is hard to understand. People don't have an intuitive grasp of physics. In fact, in some ways, they seem to have the exact wrong intuitive thought of how physics works. But we're physicians, and everybody has a body. You can start there. Everybody's had a skin their knee at some point. Everybody's had a bruise. Everybody has watched a scab heal over time. Not everybody's had a broken bone, but everybody knows somebody who's had a broken bone. You can start with common foundations of what it's like to be human and get up to some pretty complicated concepts, such as inflammatory bowel disease. That's a pretty complicated concept, but a person who has inflammatory bowel disease has experienced what it's like to have inflammatory bowel disease. And so you can help them, they're already part way to understanding the disease process. You just need to help fill in some gaps for them about how you came to that diagnosis. So I actually, when you approach it in that way, I typically find patients or family members, in my case, very grateful that you did all that and took the time to help them understand. Now, I won't lie to you, not everyone is going to be terribly or effusively grateful and offer to write a letter to the dean expressing just how great a pathologist you are. That's probably not going to happen. I think they'll say thank you. I think in the circumstances I'm imagining that a patient calls, I think you'll rarely have someone call to berate you. I have people call and berate me, but that's because I've said something that they don't agree with. People, I really don't hear people say, well, you say I've got cancer. They may say they want a second opinion, and it's reasonable. But way down deep inside, they know they're sick or they wouldn't have come to the doctor in the first place, right? People are displeased with me when I say that something's suicide, for example, and they say, well, my child would never have committed suicide. And I know that, so I already know that you don't know what you're doing. So that's a different sort of conversation, and I'm hoping that you don't have to have that conversation. Occasionally you do get someone that's so grateful, but often not. Let's see, I think, Christina, now I'm ready to go to the slide, not the first one, but that second one. And I'm going to go through my list. Thank you. So you can pull up the first one. So now I'm going to talk about a list. Thank you. And then when I say it again, click again and we'll be good. But right, we'll hold with listen right now. So when you talk with a patient, these are the things that you need to do. The first thing and really important thing you need to do is listen. Listening is how you learn what the patient's questions really are. As I mentioned, oftentimes what I expect, and I've been doing this for 28 years, oftentimes the question that I expect the patient's going to ask, the patient never even asks that question at all. They may ask something completely different. I may be ready for them to want to know how I determined that someone died of a gunshot wound. It's pretty easy. Nobody really questions that, but maybe, or pneumonia. We'll say pneumonia. They want to know how I can know that their loved one had pneumonia. And all they want to know is, when's the death certificate going to be completed? That's a perfectly appropriate question. Very different from any sort of medical question that might be asked. So listen to what they say. Don't start talking until you've listened for a while first, and then continue to listen. Next, be respectful and polite always. I don't use the word always casually. It's a really important word, but you've got to be respectful and polite, even if they become rude with you. Now, there's a polite way to handle rudeness. And the polite way to do it is to interrupt it, because I've had people curse me before, and I stop them and I say, you've called me to ask me questions. This is a professional conversation. If you can't talk to me in a polite and professional manner, then I'm going to stop this conversation and you'll have another chance again tomorrow, but you will not have another chance today. And when I have done that before, the response I usually get is, I apologize, I'm just upset. And I say, I regret that you're upset in this way. Let's just keep talking. Let it go. I did have one person continue to curse me. So I said, this conversation is now over, and hung up. Of course, they called right back and wanted to talk to me. And I said, no, tell them I won't talk. I said 24 hours. They can try again tomorrow. So, but always be respectful and polite. Next, if you're listening, but you may not always understand what people are asking, and they may not know exactly how to articulate what it is that they want to say. So if you don't understand, ask questions of them. Try to refine your understanding. Oftentimes, in my case, if this is helpful to you, in my case, it helps people for me to say, could you tell me a little bit about the person that died? And they always brighten up. They always, you can hear that they're smiling. And they usually don't say, he was the meanest old son of a gun ever, and I'm glad he's dead. They never say that. they always tell me something about how special this person was to them. So ask questions, and you can ask questions like I just alluded to help you establish rapport with the patient. Next, please. You need to be aware of your environment, and that requires observation. And sometimes, particularly if it's a telephone call, this observation is just listening. But when somebody calls me, I've already mentioned that I don't have distractions for me, but when they call me and the television's going full blast, and then they say something like, "Y'all hush up now, I'm trying to talk to the medical examiner," and that sort of thing. I'm polite, I'm engaged with them, I try to tell them, but it tells me that they're not fully engaged with me. And so they may not catch everything I say. In any event, just be aware of the environment and what's happening and try to respond in ways that are appropriate. Next, please. Answer the questions that the person asks of you. If I wish my father would do this better, but if they ask you when the death certificate will be ready, don't start telling them about how you make a diagnosis of carcinoma in situ. They don't want to hear that. They want to know when the death certificate's going to be ready. So answer the question that they ask. Maybe it's about billing. Yes, next, offer your thoughts as appropriate. It's fine to interject and add to the conversation. They may not realize something that you know that they would like to hear based on everything that they've asked. And finally, there's one more. Maintain your emphasis on service, because that's what you're really there to do. You're there to provide service because you care about people. That's why we were supposed to go into medicine. And if we'll do all this, then I look forward to a day where there won't be some clinician that's between us and the patient, where we'll come out of the laboratories and we'll talk to patients directly, because that's what we do. And we're confident and able to do it, and patients will appreciate it, and we will have a better sense of how important we are in patient care, and we'll actually appreciate it too. There are plenty of times that I can't believe that the person on the other end of the phone got more out of the conversation than I did. You can ask questions too. Clinicians don't always know all the questions. I definitely refine some of my understanding of a circumstance by asking the patient a few questions myself that no one has thought to ask before. So ask them. They called you. They've opened the dialogue. It's a good time to ask. I have whole other talks that I give about interacting with attorneys and that sort of thing. This isn't the time. I don't have the time to do it. I'll just simply say here that all of these same principles, which are old principles, that's the old part. You were taught this in medical school. It's just how to interact successfully with people. Apply all these old established ways of interacting in new ways through social media, if you wish, but use these foundational rules for successful interaction, and you'll have successful interactions on all levels, whether they're new technology or old. And with that, I'll stop and give Mr. Gravlin his time. I don't know if you want questions now or at the end, Christine, I do not know.
I don't have a preference, but I just want to say thank you for that. I think everything you said is definitely applicable. I can't even say the word. It applies across all disciplines of medicine, but beyond. And I think your segue into the legal sector mentioned, we'll just let Jeff go ahead and take it from here, since he's the attorney on our panel, and then maybe save questions for the end. And if that's okay with you.
Sure, I'm here.
All right.
I want to hear it. That is what Jeff Gravlin has to say.
Same. I do as well. Jeff, did you want me to share the slides, or were you going to do that?
I can either screen share, or if you want to, it doesn't matter to me.
Okay.
Well, I can screen share. Yeah, I'll go ahead and do it.
Okay, great.
Can y'all see that?
Yes.
Okay. That's a hard presentation to follow. I'm glad there's not a big, huge mass exodus of participants. So I'm glad to see everybody has stuck around for this. First, I want to thank you all. Thanks, Christina, for inviting me, and thanks, Dr. Davis, for letting me have some of your time. And thank you all for for taking time at lunch. I see a number of familiar faces that I've worked with over the years, so I'm happy to see you all here. As I was kind of preparing for this, I was trying to think of how to tie it back to networks, old and new. And I was thinking, so I've done this at UAB for quite a while. For the past 15 years, I've been here doing essentially this. And I think about how do we in academia learn about copyright. And from what I've learned over the years is that it really is through your professional network. So it's your colleagues, it is your colleagues on campus, it's your colleagues throughout the profession. And so that's kind of how I want to tie this back to, networks old and new. So like I said, I've been here and I've worked with a number of you over the years on these copyright issues. So that's part of the old network. And the new Office of Scholarly Communication, which we launched in the UAB Libraries just this year, earlier this spring, is part of the new network. So I want to bring in all of that information that we used to kind of provide informally into the formal setting of this new, I'm going to call it the OSC, so I don't have to keep calling it the Office of Scholarly Communication. So kind of keep that in mind as we talk today. So you all are now part of this new network and the copyright and OSC network here. I'm not going to do a copyright presentation. Really what I'm going to do is introduce you to the OSC, tell you what it is, why we created it, and what kind of services we offer. I'm really excited about it. I'll be happy to take any questions. I can see the chat box down here. So if you have any questions as we go, feel free to make them aware of it, or take advantage of that. So let's see if we can go to the next slide here. All right, so after doing years and years of copyright presentations and workshops on author agreements and data management and all types of things with faculty, with staff, with various departments around campus, I've wanted for years to start this OSC as a central place that everyone within the UAB community can go to get advice on any topic they have that relates to their scholarship and teaching. And so that's what we did here. I do want to preface it by saying this is not legal advice. No advice I give through the OSC is legal advice, so I've always got to give that caveat. So all of the things that we'll talk about, the services that I offer, are offered either face-to-face now that we're kind of back on campus, so they can be face-to-face or they can be virtual, and offer a whole variety of different support services on campus. So I'll kind of run through them, and if you have any questions about them, kind of let me know. So the first thing and the biggest one that we offer right now are copyright and one-on-one consultations. So this could be if you're doing a presentation professionally, if you're doing a class, if you just want to know what you can and can't use, I'll be happy to work with you on that. So I work really closely with e-learning, with the CTL on these consultations. The next thing I do are on-demand workshops. So if you have a presentation like this today, or if you have a presentation on a specific topic that you want, I can come and talk to your department or to your school or just to a group of folks and answer whatever questions you have. So for instance, tomorrow I am meeting with a group of course designers on campus, and we're talking about image use in their courses. So what can they use on websites? What can they use when they're designing courses? And we'll kind of walk through it, and I'll teach them what they can and can't use. And that opens up a whole additional network for them and for me. So they know when they have a question, they can come back to me to ask, and then they can refer others within their networks back to the office to get help with that. I do answer emails. All of the emails that come through the OSC website come directly to me, and I usually get back within a couple of hours. So any kind of questions you have, I'll be happy to answer those. Another big area that I really enjoy working with folks on is understanding publishing agreements. So these could be chapter agreements, agreements for book chapters, articles, journal articles, It could be agreements for conference papers. So I had somebody contact me last week about using some copyrighted material in an international conference that they were presenting over in London, and we had some questions about that. So a whole variety of things of what, that I can help you with the agreements. And, like Dr. Davis said, since I do have the legal background, I try to avoid using legalese. When I first started doing this, when I first came to UAB, I was right out of private law practice. And so I made it much more difficult than it needed to be. And I used all the very technical legal terms and realized that eyes glazed over very quickly. So now I try to make it as easy to understand as possible, putting it in everyday terms and things that people can understand. So one of the things I always try to do, everybody has seen the all rights reserved mark on things, that they see copyright all right reserved. So I spend a lot of time talking about what that means and how it actually relates back to what you see and what you do here at UAB. So I try to make it in really understandable terms, but I can walk you through your agreements. Like I said, if you're teaching an online course or if you're giving an online presentation, I can give you some copyright compliance guidelines on those things. I can review your materials and give you advice on that. ORCID IDs and Scopus IDs, I work on that. I'm also on the UAB Profiles and Scholars team here. And we do a lot of work with ORCID IDs. With federal funding now, the ORCID IDs are becoming more and more required. And so there's more of a push on campus for that. And I get a lot of questions about them. And very often people, they'll say, well, I wasn't even sure where to go or who I could ask. So now if you ever have anyone that has questions about these, they can come to me and I can either answer them or point them in the right direction. And then finally, one other thing, especially in the libraries that we really like to support is open education, which is educational materials that are free to students and freely available on the web that are no cost at all. And then affordable instructional materials, which are not necessarily open and free, but they are free to the students. It means that, say, the library may pay for them, the university may pay for them, but there's no cost to the students. So if you're teaching courses and you want to make them more affordable for your students, this is something that I can help you with. I've taught in the graduate school in Tuscaloosa for the past 20 years. And really during that time, there's been very few times that I've used an actual textbook. I've always tried to use either open access or affordable instructional materials to really tailor the courses. So I do have experience with that. So these are the services that I offer. And when I say the Office of Scholarly Communication, right now it's just me. So I am the office, so all of these questions come right to me. And we are planning, so I've got a 3 to 5 year strategic plan for the office, which includes adding some additional folks in the office. And the first thing we're going to focus on is assisting with data management. So it can be just your general data management plan, where you're going to store your data. And it can also be with compliance with federal funder mandates. So NIH, NSF, all these other mandates. And so we're working through hiring somebody that can assist me with that right now. We're in the process of launching an institutional repository in the UAB libraries, which is going to be different than a data repository. So those are two different things that we're going to have. But this will be things if you are hosting say a symposium on campus, if you have a campus journal that you would like us to host, we can host all that information for you. If you can also put your scholarly research in it as well. So kind of be on the lookout for that. We're hoping to get that launched this fall. And then finally, I do this now, but we're hoping to make it a more robust service, is assessing your scholarly impact. So looking at the journals that you publish in, the impact factors, and looking at your scholarly web. So those are what we do and what we're going to be doing. The office is very easy to find. It's on our main library's webpage, and it's prominently displayed right up at the very top. It's the Office of Scholarly Communication. And let me show you, let me change the share screen here. Okay, that should be the live, the live view. I'll just kind of show you what it looks like. It's very similar to what we had, which you already saw as far as our services. So it gives the outline of the services. It's got some basic information about these various copyright and scholarly communication topics along the left bar there. Really, the point of this is a funnel back to me or to whoever else is in the office to give really personalized advice. Because a lot of times, if any of you have ever worked in these areas before or had copyright or publishing questions, 9 out of 10 times is the answer is that it depends. It's very fact dependent. It's very circumstance dependent. So while we can give you information that's static on the website, the best way to do it is to talk to me, and we can walk through your specific scenario, because one fact can change it. The 2 other things I'll point out on this are the ability to submit a question. So you can submit a question here by clicking that link, and it will take you to a form where it's sent right to me. So whatever questions you may have. You can also request a one-on-one or a group consultation or presentation right from this website too. So it's really easy to set these up. And then finally, the contact information on it that's me. So that's all I've got. I really do appreciate y'all taking time to listen to it. And I hope that you'll take advantage of using the new office and referring your colleagues to it as well.
Thank you, Jeff. I know I'm not a scholar and I'm not publishing, but I do get asked questions about almost all the things that you touched on and that your area covers. And so I am thrilled to know that you are here as a resource, and I think others will be as well. I'm going to go ahead and leave it. Oh, go ahead.
I was going to say, Jeff, this very, very interesting services that you offer. I'm serving as interim division director of lab medicine, and we have our faculty meetings every month. And I like to bring people like you to speak about these things that to us are somewhat of a black box. We know we're not supposed to use certain images, but we use, nobody says anything. So it's like, okay, I guess it was fine. So I was wondering, I wanted to make you an invitation online. If you would be available. We have the next faculty meeting is July 14th, Bastille Day. At 3 p.m. is our next meeting. And I usually, I like to have a speaker, and I don't have a special presentation for this one.
Sure, I'm wide open that day. Just follow up offline, and we can schedule. We can talk about what you want and the times and everything. I'll be happy.
Yes, I think that I would like to also for you to. Yeah, we'll talk, but it would also be good for people to ask you questions, like. Yeah. And to know that you exist, like Christina said.
Yes, that's the big thing. That's why I love to do these things, is so that people know we're here to to help them with whatever question.
Right. And then there will certainly be questions. So very good, great session, Christina, Greg, and you're very, very informational and useful.
I do want to share, since we have a moment, and hopefully Dr. Davis will forgive me, but I don't want to underestimate, I want people to know on this call who've taken the time to be here how recognized he is in his field and respected, and also just that he has seen so many things that, well, let's just say most of us probably haven't. But I think there's one great example I'm going to share here on can you see this 50th anniversary website here? So Dr. Davis, of course, was involved when the tornadoes came through well, I guess it's been a decade ago now in April, and his office constantly has to deal with things like, obviously not necessarily of this magnitude, but just the emergent disasters and the after effects. And if you have a minute, this is a really great recording and story that he told with a colleague about their work immediately following those tornadoes. It's really interesting. but it's one of many great stories that he can tell. So
Thank you, Christina.
sure. Does anyone have any other questions?
Greg, I would say this would be what you just said to this group would be good to talk to the new residents coming into pathology.
You know, I would be happy to do that, Marissa.
And
If
I think
only
Dr.
knew
McCluskey
someone who
could
had
have-
authority over the residents.
Has Dr. McCluskey already asked you to do that? Is
No,
still
she
there?
hasn't.
I just want to thank the speakers as the fly on the wall being the PhD in the room. I'm always curious about what the rest of the department's doing. So it's kind of fun to hear the other side. So thanks for sharing. I got another meeting. So thanks again.
Thanks for being here.
Well, Marissa, since you spoke, one thing I had meant to say and I forgot, but what if we started writing our reports so that they had a portion that was for patients, where we don't just say adenocarcinoma, comma, invasive, comma, ductal, or whatever. I'm sorry, I can't do it in blood bank because I don't
We know what you're trying to say.
Yeah, but what if we just had another little section that said, here's what this means in everyday terms. If you have a question, you can call us. I know that Brandy, when she started with us, started sending sympathy cards
I remember that.
to families, and about, I don't know, 1 in 50 of them we get a response, but the responses that we have gotten have been overwhelmingly positive. People send us I've never before received a thank you card for a sympathy card, but they do. Or they send us the bill, the little order of service from the funeral. It's really, I think we should consider.
Well, you know, that's more anatomic pathology, surgical pathology, and that's not my area, but I think that's a great idea. We could talk to Christina.
But I think you do have, so for example, if someone's getting a test for sickle cell trait,
True.
that would be the sort of thing that you could
Yeah, you're right.
explain in those terms.
And they could be we have the patient portal. It could be an area where in the portal where these patient specific communications would be.
Yeah. And in talking with someone over the weekend, he's at Yale, but he was saying that the portal, actually, they have tried to become active in this, and that is an essential component. That's how they know it's not just like a nosy neighbor calling and pretending to be that person. Obviously, HIPAA makes requirements of us that we be certain we know who we're talking with, and the portal is the way to do that.
You know, the portal, our portal, UAB portal, refers the patients to an online lab, to a commercial lab, to understand their lab reports. If you have a question about your complete blood count, go here. It's like, we're not here to help you, go somewhere else.
No, we should be here to help. And it's not everyone that's going to call. Many will not.
But
Most will not.
people do call.
But a time or so a week, I usually get involved in this sort of thing.
Yeah. No, it's as you said, we all have a lot of things going on. So something like this is a big project. It needs to be thought through. So hope there'll be some young person willing to.
I'm taking notes. I'll follow up. That's something when I started that, and I have seen some clinical reports from laboratories outside of UAB, and some of them do have even like specially designed graphics to explain if it's the specific like urology's, clinic or something like that to help break it down for the patient a little bit more. So there are definitely things we could be looking to do, but
and we can start small.
That's right. Well,
great ideas.
Does anyone else have any questions?
No, thank you. This is good. We have to attend. We have another meeting to attend.
Okay, great. Well,
this one was more fun, but sorry.
I'm glad to hear it. Okay.
To be present in the next one.
We understand.
I'll email you, Jeff. Nice meeting you.
You too.
All right.
Yeah,
Thank you,
bye-bye.
everyone, for participating, and hope to see you at the next session. That was my last thought. We have another one coming up in July,
Mhm.
the third week of July, which is the 15th, I believe. Excuse me.
Yep.
So, and that one really is about social media, and it's specific to pathology. So if you're interested, please join us.
Will do.
All right. Thank you.